I'm going to answer the question about targeted therapy and precision oncology. There's a very dear Raza family friend who once told my younger brother Abbas a very interesting story. He said, "Look, Abbas, if the sun rises from the west one day, everyone will stop and wonder why. But there are some people in this world who watch the sun rise from the east every day and wonder why. And they are the only ones who will make a difference." So the point I want to make is that in oncology we have been taking a lot of things for granted. It's time to question some of the very practices that we have been involved in for decades. There's a general impression in the public that cancer treatment is increasing and improving and getting better with time. Mostly, I would say that the improvements are related to better use of existing therapies rather than dramatically new therapies, except a very few that help rare types of cancers. In general, to treat cancers, we are still relying on the age-old surgery, chemotherapy, radiation therapy that somebody has described well as slash, poison and burn. Yes, we have learned to use these better, and yes, survivals have improved as a result of that. But my question is, why after millions and millions of papers written in cancer and billions of dollars spent in research, why have we not found something better than these draconian measures? The best improvement I can name right away, because my field is leukemias or bone marrow cancers, I can say that there were 2 leukemias where truly dramatic improvements occurred. The first is chronic myeloid leukemia. In this disease, there's a particular genetic change that drives the whole disease, and blocking that has led to cures. And the second one is acute promyelocytic leukemia, which used to be a deadly, almost universally fatal disease when I was in training, and today is curable with a vitamin. So the idea is that if we can find the right target, yes, we can cure the diseases. So these 2 fantastic advances in leukemias have helped millions of patients, but had a downside to it, because they also seem to confirm a paradigm that all we have to do is now look for similar one gene causing one cancer everywhere else and then develop treatments for blocking that. It turned out that most other cancers are far too complicated to begin with, and they constantly change dynamically. It also led to development of an enormously popular project called precision oncology. That means we will find in individual cases what their tumors have as the driving protein or genetic mutation, and then treat them with specifically tailored, precise therapy. This precision oncology initiative got a lot of support from the National Cancer Institute, from many different groups dedicated to developing better treatments of cancer in the country. And a match trial was started in 2015, which had maybe 20 arms to begin with, and I think it's mushroomed to something like 30 or 40 arms by now. And the idea was that we should just take as many tumors belonging to different organs as possible, go ahead and sequence them, find the mutation which we suspect is driving the disease, try to match it with an existing drug, and then see what happens. Well, to begin with, not that many mutations were identified, at least as far as the more common type of cancers are concerned. By that I mean breast and prostate and lung and colorectal cancers. Rare tumors seem to do a little better in this, but for the common cancers, very few, maybe 5 to 15% at most, patients could actually have a mutation that could be matched to a drug. But the bigger disappointment was that even when the drug was correctly matched to the mutation, it didn't guarantee a response. In fact, only 30% patients responded. And the worst thing was that the response was not curative. It only lasted a median of 6 months at best. And so, even though precision oncology is by no means dead or finished, at least the expectations have been dialed down seriously. Thank you.